Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians, and people with lived experience
to support your practice in being more evidence-based. Well, hello everyone. Thank you so much for tuning in again to delve into our new season 5 of the podcast. Can't believe we're there. And today is going to be a very exciting episode. I have to say, I'm a huge fan. I've been doing a little bit of fangirling already as I've been preparing for this podcast. We have two incredible guests with us today, and I'm sure that everyone is going to love this conversation, the practical implications of this, which is why I'm so excited. So welcome to the pod, Dr. Sue Greaves and Dr. Brian Hoare. Hello.
Hi, Dana.
Hi, everyone. Hi, Dana.
Thanks for having us.
Oh, it's such a pleasure to have both of you here. We've got so much to talk about today, and this one, we really will be talking about two papers. We'll see how we go with it. But these are your latest publications published recently in the Journal of Clinical Medicine. So the main focus paper we're going to be talking about is upper limb therapy for infants and young children with unilateral cerebral palsy, a clinical framework. And we'll also then be bringing in a follow-up paper that was also just recently published just this month, Barriers, Facilitators, and a Proposed Model of Care for Implementation of Upper Limb Distributed Practice Approaches for Children with Unilateral Cerebral Palsy. So before we get into the paper, I do need to introduce our guest today to give you a bit of an idea of who they are and why this is such a significant podcast episode. So firstly, Dr. Sue Greaves is a leading clinician and researcher in paediatric occupational therapy, specialising in early intervention for children with unilateral cerebral palsy, and she's with the Cerebral Palsy Group. She's the developer of the Mini Assisting Hand Assessment, or the Mini AHA, and an instructor for both the Mini AHA and the Hand Assessment for Infants, or the HI courses. With extensive experience in upper limb rehabilitation, Sue's work focuses on translating evidence-based motor learning principles into clinical practice, guiding therapists in delivering effective therapy during the critical early years of development. Now, Dr. Brian Hoare is the director of the Cerebral Palsy Group and is affiliated with the School of Allied Health at the Australian Catholic University and La Trobe University, where he contributes to advancing knowledge in paediatric neurorehabilitation. Brian is widely recognised for his expertise in upper limb therapy and has been instrumental in developing and promoting motor learning-based interventions, including constraint-induced movement therapy and bimanual therapy. He is, as you will hear, passionate about ensuring that research findings translate into practical, impactful clinical strategies for therapists working with children with disabilities. So clearly there's so much that's aligned here. Brian and I have met previously on at the conference actually in Europe. I can't believe that's where we first meet, is overseas. And we have often just stood there talking about motor learning strategies with great excitement. So yeah, really excited to go into this. But before we delve into it, once again, we're going to do icebreaker question. Now, unfortunately, Ash isn't here today, so the duties have been handed over to me today. And hopefully, Ash, as you're listening, I hope you're proud of this. But I've given it my best go. Because we have two guests today, I thought we could do some fast fire questions. So I've got 10 questions. First thing that comes to mind, Brian, you go first, and then Sue next. We'll see what you have to say. These are going to be questions that will change your world, I'm sure. All right, the first one. You ready? Okay. Crisps or chocolate?
Depends on the mood. I'm ruined it already.
Controversial from the start.
But
Good on you,
both.
Brian. Yeah, I'll just go chocolate, thank you.
Nice one, Sue. All right. Dogs or cats?
Dogs.
Lovely. I'm a dog fan too. Text or call?
Call.
Nice.
Cool.
Yes. This is our generation. Watch a film or play video games?
Watch a film. Gosh, we're showing our age here, Brian.
this is definitely my jam. It's good. Okay. Chinese food or Indian food takeaway?
Oh, depends.
Right.
Both.
No, I'll go the Indian.
Indian, nice one. Okay, new shoes or new haircut? Profound questions, I know.
Shoes.
Well, you got short hair. Yeah. No, definitely shoes. I'm a Melda Marcos revisited.
Oh, love that. I love that. Okay. Big night out or quiet night in?
Oh, depends.
Yes. Again, showing my age, quiet night in.
Yeah. Not quite there yet, Sue, so I'd say yes, either.
Look, I can see where the different moods come in. This one is going to be interesting. Instagram or TikTok?
Neither. If there's one, Instagram.
Yeah.
I would agree.
Yes, I don't even think I've got a TikTok account, so I'm going to have to go Instagram. So
look, I would agree too. Every time I've just dabbled into looking at TikTok, it actually frightens me because I'm like, I don't know what this is. I didn't follow you. Why are you coming up with this? And then all this data talk as well. Yeah, that's got me scared. Okay, the next one, swimming pool or beach?
Beach.
Beach, nice. Very
Definitely.
Australian.
Yeah.
Okay, this last one I feel is really telling. Would you rather lose your wallet or lose your phone?
Lose my wallet.
Lose my phone.
Ah.
I don't carry a wallet anymore.
Yes.
Everything's on my phone,
Yes,
so
that's right.
therefore it's
there
a
you go,
bigger deal.
Brian. Yes. No, definitely my wallet. I'm still an old person. Though I don't use cash anymore. I'll give you that.
Yeah. It's funny, isn't it? Like how that transition really happened. It must have been during COVID because I have like this little mini wallet with me now and I just want to make sure I've got my driver's license on there and just those cards. But then you can actually make them all digital now. Like your driver's license is still physical, isn't it? Though?
Yes. No, you can get a digital driver's license now.
Yeah.
So, yes.
Can you?
And all my keys are on my phone, house and car.
Gosh.
And so, yeah,
Gosh.
I don't need a wallet.
Wow.
Yeah.
Okay.
Interesting. You have to teach
lot
me
to
that then,
learn.
Brian.
I was going to say that actually sounds very useful because
The
I
future
would
is
say
here.
the future is most certainly here. Do you use your watch much? Do you actually have stuff on your watch? Yeah. Do you as well, Brian? Yeah. Look, I've just recently gone into, normally I have a smartwatch and now I call it a fake watch. It's not fake, it's a real watch. It's just, it doesn't have any of the tingles because it was always beeping at me. But now I'm like, oh, what's happening? So anyway, I feel like I can't quite get it right. I hope everyone enjoyed that. Profound questions, I know, but let's get straight into what we're going to be talking about. We can make our judgment call on whether any of the way that you answer these questions influence how you write this paper. I don't know. I feel like there could be that. We'll bring it in. All right, so this paper presents a structured approach to early intervention for infants with unilateral cerebral palsy, recognising the critical period of brain development in early childhood. Evidence-based strategies to optimise upper limb function through two major therapeutic approaches, constraint-induced movement therapy and bimanual therapy, are discussed. A detailed clinical framework is presented to guide therapists in selecting and implementing these therapies based on a child's specific abilities, family context, and developmental goals, whilst emphasising the importance of motor learning principles, goal-directed practice, and the integration of therapy into everyday activities to maximise outcomes. This paper also highlights key considerations such as therapy intensity, home-based programs, and the role of perceptual and cognitive development in motor skill acquisition. So everything there is a buzzword for me. Let's go back to the beginning here and make sure we can set the scene. So the main population we'll be talking about today is clearly children with unilateral cerebral palsy. Can you start by giving us a bit of a background on how children present and what is being delivered from a therapeutic perspective? Who would like to take this one?
Oh, I will. I'll start.
Okay, great.
So there's definitely been a push for earlier identification of children with cerebral palsy. I'm sure you've interviewed lots of people about that, Dana.
Yeah.
So which is a fantastic thing. So I think that this kind of the way they present, therefore, can be now a little bit different. So, they may present at birth, so they may be in an event at birth, such as a seizure or something like that, which sets off alarm bells that there's been some kind of neurological incident. And of course, we've got all these wonderful new assessment tools like, they're not new, but assessment tools like MRIs and general movements and the high and the high, maybe a newer assessment tool, but all can help identify whether these babies are at risk or, do have unilateral cerebral palsy. So we can do this early identification, but I guess in terms of thinking about the upper limb, it's a bit of an emerging picture over the first year of life. So, we might see it, first of all, as an early hand preference. And, for those kids who don't get identified early, that is often what, parents will go to a GP with. They might say,
Sure.
oh, my child is right-handed. I can tell they're only using their right hand, and which should actually be alarm bells and red flags for the GP. But that picture of upper limb impairment actually is a bit of an emerging picture over that first year of life.
Sure.
So, the typical upper limb picture that we see, with children, like elbow flexion, wrist flexion, fist to hand, thumb across palm, that might not be evident first up, but, as they develop their motor skills over that first year of life, we start to see that more and more.
Right.
Or we might see some dystonic posturing more and more.
Yes.
So it is this really kind of emerging picture over this first year of life. So in terms of the second question, with regards to what's being delivered from a therapeutic perspective, I guess we're aiming to take advantage of that early identification.
Sure.
And, really aiming to get therapy in early and, maybe, try and prevent some of those outcomes that we might see, like, learned non-use or, or using strategies that may be, less effective. So, I guess that basically the aim of the game is getting quick and get in early and don't wait to see what emerges.
Right. Let's really
try and influence it.
Yeah. And can I ask on that, because the early hand preference, which we know is a bit of like a, red flag, we know to look at that. When do we know children typically show a hand preference? Because I think knowing that is also really important, isn't it?
Yeah. And can I answer that?
Yeah,
so
sure.
Go for it,
lucky. We're really, really lucky because when they developed the hand assessment for infants, the lovely Swedes and the Italians did some great work in this area. So they looked at 492 typically developing babies from Italy and Sweden. And they did the hand assessment infants with these babies. And they actually found that very, very, very few babies have an early difference between how well they can use their left hand and how well they can use their right hand.
Right.
And so, this was with babies up to 10 months of age, that there were very few babies which showed any difference between them. So I think that's really great research to show that, that if a baby is showing this early preference, that it should be a red flag and it should be further investigated.
So with that context in mind then, I've alluded to how fabulous these papers are and I'll go on about that. But what was your motivation behind putting together this paper? You're obviously trying to fill a need there. What was the motivation?
I'm just going to answer that quickly first, and I'm sure Brian will jump in.
We both got probably differing motivations.
Yeah. So Brian and I have been very privileged to work in large, pediatric teaching hospitals for many, many years. I worked at the Royal Children's Hospital in Melbourne for 25 years, and I know Brian worked down at Monash Children's Hospital for many, many years. So, and we were involved, very privileged to be involved in a lot of research and a lot of a big clinical hospital setting kind of events. So which was just fabulous. But at heart, we are both clinicians. We are passionate clinicians. And we've always, kept that, that clinical perspective. But now we are both purely clinicians. So, because we work in a private practice, but that is a really strong motivating factor. And I've worked for many years in pediatrics in community settings. And I believe that, that recognition of the difference between, research work and working in a big teaching hospital as compared to working in community is really important to recognize the difference.
Absolutely.
And really, really supporting people who are in clinical practice, translate this wonderful research work into their practice. So that's a really big motivating factor for us to write this paper about, how do you translate these important clinical findings into your own clinical practice.
I love that. That's
Over
so
to you, Brian.
significant, really significant. Yeah, Brian, what do you have to say?
Yeah, I mean, obviously we share the same motivation, and thanks, Sue, for that background, because I think it is really important of where we've come from and where we are now. And I think, I mean, we have worked in the bigger organisations. We're now sort of in private practice like lots of clinicians across Australia because of our National Disability Insurance Scheme. But I think the thing that always gets me, and this is what drives me and has driven me for 25 years now to sort of continue in clinical practice, but also to do research, is I remember vividly, like it was yesterday, being a clinician in an organisation seeking information, and it really was non-existent. And I wanted the guidelines. I think there's almost an assumption that you finish university and you know what to do. Well, the answer is you don't. No. You get a way of thinking in your discipline-specific courses, and then you learn your skills on the job. But if you don't have that information, and so that's in fact why I started doing research, because I wanted to know, I'm being taught this stuff, but is actually this the most optimal way I could be supporting kids and families? And it wasn't. And I think we've demonstrated that. And so now I still think of that and the position I was in, and I really want to provide resources for clinicians who are in the same boat of going, what do I actually do? And there's been such a huge amount of research by some amazing people, lots of Aussies, which is really exciting in this space, who've made a contribution for us to understand now what we should do. But that's one thing, knowing what we should do, but then how do you do it? And that's then led me into teaching. And like Sue, we do lots of teaching. I'm now taught over 2,500 clinicians. And I love doing that because, again, it meets this unmet need of education around what we should be doing. But that then leads into, why do we write this paper? And Sue and I have had the opportunity to write some fun papers, I think, meaningful, because because we are clinicians and we do research as an adjunct, really, to guide our own clinical practice for sort of probably selfish reasons. But then we need to share that information. That's why we teach. But so I think, and like Sue, in our courses, we get peppered with questions for 2 days or however many sessions we're doing. So I think we have a unique also from the courses that we do. What are the gaps and what do people want to know? And I think these two papers actually meet. I've wanted to write these two papers for a long time, and it's great to finally have them in print to meet that, to sort of really answer all the questions that we get all the time on our courses from clinicians.
And it really does truly read that way. When you look at the paper, and I really encourage everyone to look at it. We'll have links for this, of course. When you go through it, you've really given a practical guide about how to implement what we know is in the research. And you're absolutely right. I mean, that's why we started the podcast is, one, we need to know about this stuff that's come out, and it's so critical for us. There are resources out there. But to assume that research is done and it's then implemented is really, we now know it doesn't work that way. We'd love it to be that way, but it just is not. There is this absolute need for that implementation, which is why your second paper is so fabulous. I saw that you used the CIFA in that one, and I absolutely love that. So that's where a lot of things are shifted at the moment. So you guys are really leading the way in that. So with that motivation in mind and your training and your teaching and your skills, I thought now we can just kind of delve into those two interventions about what they actually are. I think for a lot of people, they would have heard about it. So OTs will probably all know about it. But even if you're not an OT, we need to know about these interventions and talk about them, because obviously you don't chop children up into different parts and, you do this and you do that. That's not how it works. So let's go through the first one, which is constraint-induced movement therapy. Can you take us through what this is, how it was developed, and why it was even developed in the first place?
Yeah, I'm happy to
go for it.
Take this question. And I think so. Perhaps reflecting on the past, and 15, 20 years ago, there was no such thing as constraint therapy, no such thing as bimanual therapy or goal-directed training. So there's been this massive shift in terms of just this introduction of these approaches. So there is a lot of unknown about, well, what are they? And there's now this deluge of information. So it is important to go back in time and where do they come from and why were they designed and what are they? So I think SIMT is quite easy because Professor Edward Taub, in fact, picked up on some studies that were done in Germany in the early 1900s on this sort of learned on use type phenomenon. He then started a lab at the University of Alabama in the 1950s. It's a long time ago.
Okay.
He's still alive. He's obviously retired, but I think he contributed to a conference last year. So still going.
Amazing.
And we have to acknowledge that basically it was Edward Taube that introduced this into the field. So he started with non-human primates, then started testing his theories with adults following stroke, and then sort of, and it was not until about the early 2000s that constraint-induced movement therapy was something that was documented in the literature for children with unilateral cerebral palsy.
Right.
So really it gets back to this, and it's also really important to acknowledge the backgrounds, the disciplines of where many of these experts have developed their knowledge. And a lot of our information actually comes from psychology, and Taube is a psychologist. So it comes from a behavioural perspective where whether you're an adult, non-human primate, or a child who's had a unilateral brain injury, so a brain injury on one side of the brain, that's going to affect the opposite side. So what he proposed was that very shortly after that area of injury or damage, what would happen is that the human, from a behavioural point of view, would adapt to this new environment situation whereby one hand wouldn't work as well as the other. So whether it's your dominant, non-dominant, that doesn't matter. It's just that injury, it doesn't matter how sort of severe it may be, the human starts to adapt, and that's human behaviour. You adapt to a new situation. So what that adaptation leads to is, particularly in the acute phases of, say, a stroke, is this human starts to use one hand more and neglects the other one, the more affected hand. And so that really sort of compromises the recovery of that limb. There may actually be lots of potential for recovery, but because of this behaviour change, it means they stop using the limb and don't maximise their recovery or potential. So what Taube then said, well, how can we intervene in this behavioural sort of process? And that's when he said, well, what about if you actually constrain that less affected or unaffected upper limb, and then do lots and lots of practice to actually really unmask this potential recovery in that more affected limb. And so that really essentially is constraint-induced movement therapy. It's a conditioning sort of cycle whereby you are allowing that human to, rather than every time they go to use that limb, it doesn't work, so getting punished, that's the sort of conditioning terms. You reward the use by having some success. So that's where it comes from. And now just one probably point to make, because we're talking about little humans, children who are born with a brain injury. So there's also, they don't have this ability to unmask also underlying previous function with that limb. They haven't used the limb before. So there's not this learned non-use. It's actually Stephanie DeLuca and Taube introduced the concept of developmental disregard, which is much more appropriate. So from the very first days and weeks and months of that child's life, they learn to disregard that limb. And so there's now a huge, I would have to say it's probably the most widely studied intervention in any medical or allied health. I'm happy to be incorrect, but there's so many, there's probably upwards of 50 to 60 randomized controlled trials. Hundreds of lower level studies. It's so well researched. And that's because it plays a very important part in the clinical sort of management of children with unilateral CP and their families.
Gosh, that was such a great overview of it. And I didn't realise that was the origins as well. And it makes so much sense when you do talk about from a behavioural perspective. When in relation to that, I know there have been a lot of studies around it, and we talk a lot about neuroplasticity. And sometimes I think when I hear neuroplasticity being thrown out, it has a lot of different meanings to what it actually means. Do you mind going through with us in terms of what we know about neuroplasticity when it comes to constraint-induced?
Yes. If Sue's happy, I'll keep
talking. Keep going.
It is certainly the buzzword, isn't it? And I say on my courses, if you're in a marketing department for a large organisation providing therapy and you haven't got neuroplasticity in your pamphlets and on your website, you're not doing your job well. And so, yes, it's an amazing phenomenon. And in fact, there's a book called The Brain That Changes Itself that Norman Doidge wrote. And in fact, back in the day, families would read this, and it was an amazing summary of what we know about neuroplasticity in humans. And he would go across all sorts of domains and areas of science. But the one topic or one intervention that was mentioned for children with cerebral palsy and stroke was constraint. So I would have families reading the book come in and say, I want constraint because it does this amazing neuroplasticity for these kids and adults. So I would then have this exact discussion. What is it? Well, really, we know that what promotes neuroplasticity, which is the organisation of the brain or reorganisation, if you've had sort of existing pathways, and how it is driven, essentially, or how it comes about, is active interaction with your environment. So that doesn't mean sitting there and having passive stretches done to your limb. That doesn't drive any change. In fact, doesn't do much at all, as we know. So it's that active, spontaneous initiation upon your environment that leads to neuroplasticity and obviously skill development because you're learning things. So I think it can be emphasized in a way, and it can also be sort of misunderstood that there's only certain interventions. But if you are actively engaging, and this is why all contemporary motor learning-based approaches drive neuroplasticity. But I just will say one final remark is there's actually good and sort of somewhat not good or bad plasticity that happens, so especially when we're talking about little infants who've had a unilateral brain injury. So there's this concept of experience-dependent plasticity, which is what I just mentioned. That experience, and this is why environmental enrichment is so critical to all early intervention models. And what that means is just giving these young babies as much and as many amazing opportunities and experiences in their early play with some guidance and some intervention to provoke sort of some of these more difficult things that will only get more difficult unless we do provoke the opportunity for them to practice them.
That's beautiful. Yeah.
So that's the good.
Yeah.
On the other side is we have this deprivation-induced plasticity. And so that's what's actually not often well recognised.
Yes.
So the best scenario and the saddest scenario in that is you've got a child who comes in, as Sue said, early hand preference, fisted hand, flexed elbow, and maybe some other movement or really even subtle changes. They stop using the limb. So this concept of use it or lose it. These kids have brains that have all these significant amount of synapses that they can harness through experience. But if they're not using a limb, what happens is this deprivation-induced plasticity. It doesn't mean they'll never be able to undergo neuroplastic changes, but that you're not maximising the potential. And in fact, the brain starts to organise itself in probably the not most efficient way.
Sure.
I can get technical and say you might actually start to reinforce the ipsilateral pathway rather than the contralateral.
Sure.
So that's important. And that's why kids with brain injuries cannot sit on wait lists for months and years, et cetera, because we know the secondary consequences from a neuroplastic point of view and all the other points of view is really detrimental.
That was very compelling. And I think understanding the conditions for neuroplasticity, I agree, is incredibly important because it is thrown out there with all different kinds of things. But the active self-initiation, the environment, a task, they're all things that we know in contemporary motor learning. Now, moving on to bimanual therapy, can we talk about what that is and how that contrasts to constraint? Take it away,
I'm going to answer
Sue.
this one first, Brian. Yeah, good. Well, Brian and I, as you will hear, are big bimanual therapy fans. So, yes, we very passionate about bimanual therapy. And it is for a number of different reasons. So we kind of we define it in an earlier paper, bimanual therapy, as a process of learning bimanual hand skills through repetitive use of carefully chosen goal-related two-handed activities that provoke specific bimanual actions and behaviours.
Mm-hmm.
So, but I really want to go back to why we're fans of bimanual therapy. And to understand this, you actually have to understand why you would use constraint therapy, which is kind of understanding. So as therapists, why do we use, and Brian gave a fantastic description of what constraint was and how you do it. Yeah. But, why What are we trying to achieve when we do constraint therapy? We're trying to achieve increased capacity of the more affected hand. So it's really about building skill and capacity in the more affected hand. But we're not building that skill and capacity for the hand to be used as a dominant hand. We're not building the skill or capacity for that hand to be used in a situation that requires just one hand. Just like me, as a right-handed person, I would never expect to write with my left hand or brush my teeth with my left hand or brush my hair with my left hand. I don't do that. I use my my dominant hand.
Yeah.
So why would we expect, a kid with an upper limb impairment to use their more affected hand for unimanual capacity?
Good point.
We don't.
Right.
Or shouldn't.
Yeah.
Or should not. So what we want why we want to build capacity in the more affected hand is so that it can be used as a more effective non-dominant hand or a more effective, what we would call an assisting hand. So we're really trying to build capacity for better bimanual performance. So I think that a lot of times when people are doing constraint programs, they're forgetting that is to build capacity for better, but our goal is better bimanual performance.
Yes.
Not better unimanual capacity.
Yes.
So that really needs to be front of mind and when we're doing constraint programs. But then we get another tricky thing because bimanual actions are way more complicated than unimanual actions. They involve, temporal and spatial coordination of both hands together, which involves both hemispheres and much more complex than unimanual actions. So bimanual actions are much more complicated. Additionally, bimanual actions actually involve perceptual and cognitive processes. You have to recognize that this object or this task required you to use two hands.
Yeah.
So there's a perceptual and cognitive component to bimanual therapy as well. And that adds another level of complexity as well. So we've got a more motor complexity and we've got to increase perceptual cognitive complexity to bimanual therapy. And I think that, because of this, it can be more difficult to do. But it's really, really important that we recognize this because everyone thinks constraint therapy is the answer, be all answer to everything. And, we just take the mid off and magic happens, magically they can all of a sudden do everything that they needed to do, using two hands. And this is actually not true. We actually see often in our practice that you take the mid off and they've got no idea what to do because they don't really know how to use two hands together.
Bit of task specificity
there. You get better at what you practice. If you do not practice bimanual skills, you're not going to get better at bimanual skills. So, we just said that our ultimate goal is better bimanual performance. And, you're not going to get it better at bimanual performance unless you practice it. So, bimanual therapy should be front of mind when you're treating these kids. And so that's why Brian and I are so passionate about it. Teaching people to do better bimanual therapy. Over to you, Brian. You want to add anything?
No, I think you did a great job, Sue. I think, though, the only thing I'll add, and this may lead Dana into maybe one of the upcoming topics of discussion about dosage, etc. But what I will say is, just because it's called bimanual therapy doesn't mean that the approach of bimanual therapy that you're doing is the same as what someone else is doing elsewhere. So I think it's just very important to say at this point there is the model of therapy being bimanual or constraint. And then when you unpack that and you look at the specific approaches that have been designed by different groups and different people, they can be really, really different. And that's why it's important to recognise that just because someone's doing bimanual therapy doesn't mean that it's being done in the same way elsewhere. So we can talk about that, but I think...
I would definitely want to talk about that. I'm trying not to move too much here. I'm getting a bit excited about it because it is absolutely true, right? So, as a physio, I would say people talk about just treadmill training. They go, well, treadmill training doesn't work for me. I'm like, there's actually different ways you can do it that really do promote and provide that environment for active initiation. It's the same for everything that we do. So I completely get that. I'd love you to talk through that a bit more because I think this is this is an interesting point because there's a lot of, let's go back to the Anna Tevelde and colleagues who talked about the de-implementation of NDT. I've said very clearly here, I was NDT trained probably 2008 and practiced it for many years. And we spoke about bimanual, like we did talk about it. But the theory that goes behind it is completely different to what it is that we're talking about. Over to you. Can you talk us through that a bit more? Because I think that's the conflict. There is that wrestle, I think, isn't there, about what is it actually look like? What are the key ingredients that we need to say for it to be truly bimanual therapy?
Yes. So I think firstly, remember, we've got to use these terms. What's the model? Bimanual therapy. And there are specific approaches within that.
Yeah.
Now, why are there, you've got to sort of look at why there's different approaches. Why aren't they just all the same? Well, ultimately, again, because different people have designed them, different people have evaluated them in their studies.
Yeah.
So I probably best give an example. So in my PhD, I compared modified constraint-induced movement therapy versus bimanual therapy. I designed that bimanual therapy protocol. So that was something that I went out and sourced lots of theories, and I had theories that, from my discipline-specific background as an OT, that sort of guided my thinking. But theories are a way of thinking. It's not, this is what you do in a session with a 6-month-old or an 18-month-old. They guide your way of thinking. But to then design an approach, you use these theories and you sort of operationalize them, these theories, by using strategies. This is sort of all out-of-phase work, which we've discussed before.
Yes.
So operationalizing is so fundamentally important, because if you want a clinician to go, yeah, that's a good approach, that showed a good change, I want to do that, and you go, and all it is theories, well, I don't know what to do. I think I know, I just do what I think.
Yeah.
So we need, firstly, models to just be within these sort of the approaches within models to be described really well. So let's take habit.
Yes.
So hand-arm bimanual intensive training, and I wish I gave my approach an acronym because I have to keep saying the bimanual therapy approach that I designed. So anyway,
it is paper.
that's good, but let's call it Brian's approach or something that rolls off the tongue. So habit was developed by two lovely people, Andy Gordon and Jean Charles. Jean being a physiotherapist and Andy being a scientist at Columbia University in New York. So they designed an approach, and really Andy's, and so Jean was doing her PhD with Andy. So their habit protocol paper is beautiful. It's so well described. She describes the theories and then the strategies, and it's really explicit. And within that approach, so Andy essentially picked up what he was doing in constraint therapy and said, well, it makes no sense if we want to work on bimanual, as Sue was saying before, bimanual skills, and we're working with one hand. So he and Jane designed this bimanual approach. But what is important is essentially the theories that guided the constraint were much the same as what guides their bimanual approach of habit. And what fundamentally drives habit and the theory is shaping, which is the same theory that guides Taub's approach of constraint.
Yes.
And shaping is really about sort of shaping movements in these sort of successive approximations is a sort of technical term. But for instance, if you want to improve forearm supination, you get out cards and you don't just do a couple, you do the whole deck, and then you might get out timers to change your temporal aspects. You're like a bouncer at the nightclub with your clicker, counting how many repetitions you do. It's true, that's what you would do. So you're really trying to increase the sort of amount and the dosage of repetition and maybe do it more quickly. So shaping really is about focusing on movement, say wrist extension, forearm supination, etc.
Yeah.
And that's because that's what the theory is all about.
Yeah.
Sort of high intensity shaping of movements.
Yeah.
So and it's interesting when I talked about different discipline specific backgrounds. So of course, when you're focusing on those particular movements, I think that aligns much better with a sort of physiotherapy frames of reference with sort of good alignment and good, all but better than that, Dana. I'm not so good. But as an OT, then I designed an approach, and it's fundamentally different. We don't focus on movements. We actually focus on building skills. So what might that mean? Well, it might be, say, to readjust your grip or to stabilize the object more effectively using grip. So in order to do that, you might need forearm supination, wrist extension and finger movements, etc. But we're not focusing on that. We're focusing on using objects to provoke that action and that skill. And in doing so, you'll put it all together, your sensory, your perceptual, your cognitive, and so that's where it's really different. And what is really important in the model that I designed was these cognitive theories of practice. So Feuerstein and Meekenbaum. And so I won't go into them for time's sake.
We'll do it next time, though. Yeah.
That's, a concept of Feuerstein's quickly is thinking to learn and learning to think.
Yes.
So it's very much a thinking, learning-based approach.
Yes.
It requires really, because of the strategies I'm using, like planned pauses, asking questions, expecting answers, making choices. So I'm expecting the child to cognitively be on for that active period. Now, habit is 6 hours. You're not doing habit unless you're doing 6 hours per day. That's the duration of the session for 8 weeks. So 5 or 7 days a week for 2 weeks. Now, in the approach that I designed and evaluated that showed really good effect was it's 30 minutes per day for 8 weeks. So that's a mass practice, habits and mass practice intensive model, the model that Sue and I talk about in our papers, et cetera, and baby, bimanual, et cetera, is a distributed practice model. So a different way of distributing the dosage.
Sure.
All the studies that have looked at heads to head show equal effect. Just because you're doing lots in one day doesn't mean you're necessarily getting better outcomes over a longer duration.
Sure. Wow.
So this is the important thing about dosage. It's not just you got to do this much because it's bimanual. The dosage is absolutely aligned with the theories that inform the particular approach. So for mine, it's 30 minutes per day for 8 weeks. For habit, it's 6 hours a day for 2 weeks. And that's because the approaches have defined not only the dosage, but very much the strategies that you use.
Sure.
Try getting a young child to concentrate for 6 hours per day at their upper level of sort of cognitive demand. Not feasible.
Very, very challenging. And then that's a good way to think about it. Sue, from that, what would your approach be in those sessions? Because I would say that there's so much thinking about normalizing movement. Like we're aiming for children to do something in the exact way that we might be doing it without spasticity, without a brain injury. We've spoken about this with Peter Rosenbaum before, and you can imagine what his response would have been as well. But when it comes to upper limb, let's talk about that, because it's like I want them to use their hand perfectly for everything. What should we be shifting? What should our language look like for that?
Yeah, definitely. That a shift away from the normalizing of movement. I just wanted to add really quickly just to Brian's what Brian was saying. So he also stress the importance of early perception and cognition for a bimanual approach. But this is really, really important in infancy as well. Yeah. So it's not just, I can't remember which ones you quoted, but definitely there's approaches in infancy, or frameworks in infancy that talk about early cognition perception.
Yes.
So perception action theory. There's the embodied cognition. There's things like Gibson's ecological approach, which all talk about the importance of perception and action, and how that develops in infancy. So also that's right. So babies are in this environment and they're presented with objects, and it's through their perceiving the object and perceiving the action possibilities of the object that they then act on it. And then from that acting on it, they learn, and that learning, then makes them perceive differently and act differently. And this is this whole kind of cycle of perception, action, learning that keeps on taking place. And that's what's really driving bimanual performance and driving, motor performance. So not just bimanual performance, it's driving motor performance. Yeah. And so I guess in terms of normalizing movements, we definitely don't talk about normalizing movements at all. What we're talking about are effective, effective movements. So, what is the best use of the upper limbs to quickly and effectively complete a desired bimanual goal or manual goal. So it's definitely not going to be necessary the prettiest way or, the typical way.
Yeah.
And they may look very, very different from the way that a typically developing, infant or child might use their hands. I'll give you the classic example that we always like to give. So if a child with unilateral CP has got quite a moderate difficulty using their hand, they're not going to pick up objects from the table, because actually picking up objects from the table is actually quite difficult. So they're not going to use a strategy that takes them time and lots of effort and, is difficult to do. A much more effective strategy is for them to pick up with their preferred hand, their good hand, and put an object into that affected hand so they can hold it stably to do an action on the object.
Sure.
That is a much more effective, efficient strategy, manual strategy for the child to use. It's not typical. It's not. So we shouldn't be talking about, typical ways of doing things. It's really thinking about, where is this infant at in terms of their manual performance, and what are the most efficient, effective strategies for them to complete the desired task that we're asking them to do.
I love that.
Does that make sense?
It absolutely does. I've got so many questions. Let's see if I can order them properly to ask it intelligently. So what we're sort of looking at for this is there is a differentiation here between a child initiating movement based on their environment. They desire to be part of the environment. They initiate it. Then you've got the more facilitated models where it is more about normalizing because you're trying to get a particular position to do something. So that, because the child's not able to necessarily go into those movements, that tends to be facilitated. And that's always something that is discussed. But then, we've had a lot of questions lately, which I think is so topical, is for children who have maybe from a cognition perspective, it might be harder for them to perceive and to interact with their environment. What then is the role of something like a hand-over-hand approach for them to experience it? And how does that contrast with more facilitatory, where it's more therapist-initiated movements? Can you talk us through that?
Yeah.
Does that make sense?
Yeah.
Yeah.
I'm very happy. I think this touches a lot on Adafay's work as well. I think, so the whole hands-off thing, it can be interpreted in really different ways, and I think it has. And just to say that with motor learning-based approaches, it doesn't mean you never touch the child. That's wrong. And in fact, again, that's why we try and write as much as possible now to show how. But I think then thinking, what's the theory? Why shouldn't you sort of use your hands all the time? And before I say what I'm about to say, I think it's not just hand-over-hand facilitation. I think we need to look at the modality. And so the modality of feedback we're providing is physical.
Yep.
So there's all sorts of modalities: auditory, visual, tactile, haptic. Physical is one, but there's also grading of the physical. So one is patterning, which is really from start to finish of the movement or the action. There's also then guidance, which may be partial movement within the task. And then there's sort of more of the prompting. So it might be a tap, etc. So we need to not just say, just not having go at anyone, but hand over hand. What does that mean?
Yes.
We actually need to. They are discrete strategies, and you might tap on one occasion, you might move a little bit on another, and then you might actually do complete guidance.
Yeah.
What I would say then next is, this doesn't matter about a child's cognitive difficulties or level of impairment. Where this theory comes from, skill acquisition and motor learning, does not come from therapy, does not come from this therapy sphere, comes from how do humans best learn. And whether you've got a significant impairment or not, the same strategies apply. If you use your hands too much, the kids don't learn. You also create a dependency. So I'll read this because this is the precise reason why we should keep our hands off. This is the technical bit, then I'll break it down. So Anne Gentile, who was Andy Gordon's mentor, gave him his job at Columbia University. Amazing. Human movement sort of scientist background, did neuropsychology to understand the cognitive sort of components of skill acquisition. Amazing. Anyway, so she wrote some seminal papers, and when it comes to using your hands, when handling or active guidance are used, the therapist becomes part of the regulatory environmental conditions, altering performance, context, and intrinsic feedback. So very briefly, what can we do, or what does a human experience when we're learning something new? Think about skiing, surfing, kicking a ball.
Playing golf.
Intrinsic is all that sensory, you're playing golf, all that sensory information that's coming about how it feels. And then you can supplement that through extrinsic feedback as a coach, as a therapist, to say, Sue, don't put your hands there, put them there. Now, how does that feel? So you're supplementing that sensory feedback through your words and through other modalities. So now what happens if you use your hands? Sue and I would see this all the time. I see it all the time when I'm watching other therapists, maybe on videos, or parents doing stuff, is they use their hands too much. And what immediately happens is you create a dependency very quickly. And what does this mean? If your hand's there doing the movement, guess what you're doing with this really finely tuned intrinsic feedback loop? You become part of it. Your hands are providing a sensory, you become part of that sensory knowledge when it comes, I need to do this, I need that hand there.
Yep.
So we see it all the time. And when some kids come to see us, have been seeing some other therapists, and they sit there and they wait, kids with hemiplegia, where are your hands? Where are your hands? I can't do this. And then even if you bring your hand in the visual field, they'll initiate, but it doesn't happen unless there's it. So I know I've said a lot, but what I will try and just sort of summarize, it's not about never using your hands. Yes. It's about using them wisely and carefully. It's not about discriminating by different constructs such as severity of impairment and cognition. The more you use your hands, the less the child's learning. And contemporary motor learning theory is trying to encourage kids to learn, and we're interfering with that. As I said in your last podcast, 2 things we do badly: use our hands too much and tell kids what to do. Yeah. And in fact, that's what most therapists tend to do a lot. Yeah. So we need to zip our lips and keep our hands off, and that's how we promote learning.
And so I would just add in the end. So what, because people will say, well, if you can't use your hands and you can't tell, the kids what to do, how are we going to promote learning? So you absolutely believe that the way that we're going to promote learning is by really, 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 really careful selection of the toys and the activities that we present and how we present them, and the importances of the toys that are going to provoke our desired actions. So it is that in infants, it's the toys that we're going to be using that to instead of our hands to provoke our desired bimanual actions.
And grade the environment rather than grading the physical as much as possible. So is that too big, the object? Is that too slippery? Is it too much resistance? So adapt it. Is that in a sort of awkward position? Adjust the orientation. So that's a habit. Another sort of point about that is completely and entirely hands-off. All Jean did was grade the environment. So that's because it's based on systems theory and based on, motor learning. Yeah.
I felt like that was all just gold. There's not much more to say there, apart from one thing that I think is worthwhile just fleshing out within our current context. In Australia with the NDIS, the choice and control are in the hands of the people who want the services. And there is this, almost FOMO, this fear of missing out and what's out there because everything's been marketed before them. And so, people will try lots of different things. And I often would say to people, look, if you want to try them, do so, but just do one so you can actually see the effect of that to actually gain and understand rather than all of it. But I think because the two theories and the approaches are so different, in my mind, I go, they just cancel each other out kind of thing. But what would your advice be for therapists who are navigating this when people are trying so many different things, or for parents who are trying lots of different things as well? Is there anything that you can guide them into how they can make that decision?
I mean, I think I certainly can say I have this conversation probably every time I'm in my practice. So it's a very common, as we all would as clinicians, and we know that there's all sorts of things that families can do. So what my conversation is always around, firstly, acknowledging if I had a child with cerebral palsy, I would want everything possible to optimize every part of their little being. So I know I can I acknowledge where they're coming from. But just because something sort of has an amazing website or an amazing it costs a huge amount of money does not mean that it's better than perhaps what they're getting. Or another approach. So I think there's also that natural human behavior that more is better. More money is better, more whatever is better. We know that more money often is not better at all, and more anything is often, it's maybe an inverse relationship. But what we know when we look at dosage, for instance, particularly in constraint, is the hyper-constraint approaches are not more effective than some of those lower, as long as there's enough. And that's also the important thing, is how much is enough. And that's what we need to sort of get back to. And what's enough? We'll go to an approach, whether it's distributed or intensive in nature, the way they apply the dosage, and is it effective? And it might be much lower than that other approach, and therefore might be much easier for many families to do that approach. And I think there's also, we need to acknowledge that there's differential parents' expectations around roles when it comes to their child's therapy. And I completely get it. If they could potentially see they could drop their child off for 2 weeks and maybe have 6 hours a day of therapy, I would probably expect amazing outcomes, and that's an easier way of doing it. But I don't think that's a solution. I think it is an ongoing, and what Sue and I really try and talk about in our second paper is you do really good consistent therapy early. And our model, as you'll see in the figure 3, I know, Dana, you've talked about this before in different forums, and we have together, is we don't really see the school-age kids much anymore unless they've got a goal. We do really good early intervention. We build their skills through those rapidly developing years. And then we support them in becoming independent little human beings, and then they go to school. The most important thing in their life is school. And friends and family and fun and fitness. And the function plays a little bit less of a role because they've been working on that and they're actually doing really good stuff. So I think that's our approach that we really put forward, rather than flying kids with lots and lots of therapy forever.
Yeah, and I think that, going along with this idea of this distributed approach, is one of the things that we have to do is that, we really want to involve the families in the therapy program. It's not us seeing this kid intensively without the parents and they've got no idea what this kid is doing. It is us, working with the families, coaching the families, getting them to understand our therapy and what we're aiming to achieve, and really getting them on board with the practice, because they have to do the practice at home, therefore in their natural environment, and considering their natural environment, and really trying to build the expertise of the parents so they become as expert as we are in the approaches that we're using. And I think that by, doing this with families as well, they can become more confident in the, in what they're doing and how to improve, what we're trying to achieve. And, I just think it's really, really important to mention that, supporting families in this really, really difficult time. And it is an extremely stressful time in this, first few years of life, but in supporting them to understand their child's difficulties, but to work with those, to strengthen their child to their, and help them achieve their maximal possible potential. I just think that working with families is really important, rather than maybe
truly is
paying thousands of dollars to go off to wherever to do whatever.
Yeah, that's right. And I think what you guys have both broken down so beautifully there is dosage isn't just, yes, time is one element to it, but the ingredients of what you put into that is so valuable. You can do lots and lots and lots of hours on something, but not have any of those active ingredients. And so your expectations align with that. So I think just telling people what that looks like. And again, I do want to emphasize figure 3 in the second paper is brilliant. It's a great place to start, to have a look at what that model is and what gets incorporated into all of it. And there's just so much there that you can apply practically into your practice. I guess one final thing before we sort of start to wrap up, because Ed's, I'm sure, ready for a question soon. What would be, out of all the things we've spoken about so far, your key message for therapists working with infants with unilateral cerebral palsy? Like, you've given so much food for thought here, but what would it be, if you had to pick one, what would be your one key message?
I think...
Okay, so go, Ryan.
For me, set goals, set really clear, explicit, specific goals.
Beautiful.
And support families and kids in achieving those goals.
We didn't get to talk about that
and
then,
for
did
me-
we? Like the goals set the scene, don't they? And they tell you what
Yes.
intervention. Yeah, beautiful. Yeah, good to bring it.
Yeah.
Sue.
at the end. So yes, of course, I'm going to say don't just jump into SIMT with just because a baby has unilateral cerebral palsy.
Yeah.
Don't think that every baby with unilateral CP has to do SIMT forever and a day and whatever. You know, you really need to be considered the many factors that inform which is the best upper limb intervention. And again, I hope that's what our paper really helped you choose. What is the best upper limb intervention for that baby and that family at that particular point in time?
It's beautiful. Really, really good. Well, like I said, we're not done yet. Let's bring it all together now in our final segment, Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, certainly not in this area, but he has been listening. He's been pushing buttons, moving faders. I think I had that the right way around this time. So what we'll do is we'll give you a bit of a 60-second summary. So he's got a bit of an idea of what to catch on to, and he'll have time for one question, Ed, one question. So take it away. I think Brian's doing this one.
Yeah, hi, Ed. So we have a group of babies who are born with a brain injury, and that is known as cerebral palsy. So a child has had a brain injury in early life. And over the last 20 years, there's been an enormous shift in our understanding about how to support these children, and of equal importance, their families as well. So there used to be ways in which there was lots of handling children, doing movements for them, lots of stretching, etc. So what Sue and I have done, have published 2 papers, the first of which is really about importance of early detection and early diagnosis, so not waiting for these children to get diagnosed, which used to happen. Let's wait and see. And why that's so important is because of this thing called neuroplasticity, which is really the brain's ability to organise itself. And some of the old ways of doing things really are not aligned at all with driving to good brain organisation. So Sue and I have written a paper about the best approaches from how children may be able to handle objects in their early play. And that's critical because how all children learn in the first years of their life is through play. So we're really trying to support clinicians in understanding the new ways of doing things. We think it's really unique because it's the first paper that we know of that really scaffolds these skills and really provides therapists working with kids and families about not just to sort of do anything and in the hope that these kids are somehow going to get better from just throwing toys at them and thinking that's a good bimanual toy or that's a good one-handed toy. So we hope that these papers really play a big part in supporting therapists and families as well in understanding what the best sort of principles are for early intervention and what maybe the rationale might be for the different types of therapy approaches that can be done.
That was a beautiful summary. Really good. Ed, are you ready for a question?
I am.
You are? Okay, here we go.
So I've loved the conversation today. I think I say this about just about every episode. And the looking behind the scenes of this type of these types of therapies, occupational therapy, and I think I'm going to get this right. CIMT, C-I-M-T.
Nice.
Yeah, well done.
Yeah, very good.
So I actually had like a little bit of a question about that because obviously I'm a complete novice when it comes to anything to do with the human body. Give me a computer and I'm like, okay, but humans, that's another story altogether. With the constraint-induced movement therapy, I think my question is about the constraint of the unaffected limb. Is that right?
Mm-hmm.
Yep.
Yeah.
So,
yep.
I'm curious about the kind of and I'm kind of purposely playing devil's advocate here.
Yeah.
Is just whether there was any kind of pushback from kids about how easy it can be to kind of set aside, and I'm using the wrong terminology here, but setting aside using their unaffected limb and the frustration that maybe comes into play with using their affected limb and how that kind of plays a part in how that therapy is provided. I don't know if I'm making any sense, but
Ed, no, you are. Yeah, it's a beautiful question and a really important one. And I mean, so firstly, no therapy approach should be designed or implemented to frustrate a child. And if there is frustration, you need to think about, am I doing the right thing here? And that may actually be, no, I need to stop. But what I would say is constraint therapy, like I was saying with bimanual therapy, just because they've got the same model name doesn't mean that you're actually doing the same thing. So Sue and I would implement constraint often in very young babies, and we wouldn't put anything on there. And we might actually put it in their onesie, for instance, or we might just put a clip over the end of their onesie, so like the IKEA bag clip. And that sort of really acts just as really an environmental prompt during play that stops them from grabbing the object, because this is the problem. If they can grab it, it's such a strong behaviour that's learned almost immediately. They will. So we're using it as a prompt to provide that sort of intensive use, which might only be a little bit in a young infant. So that's why we also don't really support hyper-intensive 3 hours per day and put a cast on the child's hand for 21 days, which does happen and is happening. And I don't think I can vouch for Sue and I, is we don't support that at all because we don't feel it's necessary. Firstly, with these little infants in their sleep time and feeding time and nappy changes and all the other things that go on in life, how that's not at all aligned with family-centred practice. And what I would say also is that we do and in the papers we've written is, it's not about the constraint. It's about the ability to get that child to practice with that limb. And so use the least invasive approach of of restraint. And certainly in most parts of Australia, we don't use casting. But in other parts of the world, they will cast little babies for 3 weeks straight, for instance, like they've got a broken arm. So that's one thing. And when you think about the consequence of that, that's 24 hours a day of being restrained. And I would say we'd all get very frustrated from that. We're doing sort of 30 minutes per day in the baby SIMT. So it's 30 minutes of that whole period, that awake period in a day. So there's less chance for frustration. I'm not saying there's not. And if there is a lot, you need to stop. And you need to think about what you're doing. But also you need to support families in coming up with ways of getting them so excited and creating this, again, a behavioural approach, conditioning them. This goes on. I have so much fun with mum or dad and I get to look at all these amazing toys and have this sort of uninterrupted time of playing with my parents, which should actually be a really beautiful experience rather than a negative. And if it's negative, it's not being done properly.
Absolutely. Beautiful. Emphasize that last bit is I always say the crying baby is not a learning baby. So you absolutely have to stop the frustration and you have to, I definitely agree with, short, fun sessions where the baby's really enjoying themselves, and it shouldn't be about, being a bad experience at all. It can't be about being a bad experience at all because they're not going to learn. So
that applies to everyone, doesn't it? It's not it's a universal thing, isn't it? None of us want to do it like that sort of way. So no, that was a beautiful question, Ed, and thank you for answering that. That's such a great thing to talk about and to think about. Well, I enjoyed myself. I don't know about all of the rest of you. That was just fantastic. Thank you so much, Brian and Sue, for sharing your wisdom. There's so much more about this paper that we haven't covered, but it is such a great tool for therapists. I cannot begin to emphasise that enough. We'll put links to the paper on our website, researchworks.net. And so definitely get a hold of it, have a look at the figures, do a journal club with your peers, have a chat about this because this is really significant and applies across all disciplines, really. When you think about the theories and the models, like they do apply across all of them because, how we learn is how we learn. So remember, there's also a CPD form there on our website as well to fill out to keep this as part of your record of your PD requirements. But for now, once again, thank you, Brian. Thank you, Sue.
Thanks, Dana.
Thanks, Dana. Thanks, Ed.
Thank you so much. And to everyone, we'll talk to you all again really soon. Goodbye for now.